We're speaking today with people who have been involved in researching and campaigning against corporate influence, specifically on healthcare, both in the US and in the UK. And something that involves campaigning against that particularly. It stands out from a lot of NHS campaigning, which doesn't necessarily address corporate power as a thing, which was a hope that something like that could emerge from the Corbyn movement. But there are a lot of difficulties for that to occur within the Labour Party because of its longer term commitments, essentially to what's been a corporate project. And the subject has been described as Americanization when it comes to the UK and the NHS because of a specific US influence on policy that's actually not talked about a lot among campaigners, though it has been heard a bit more. But we still, so it's specific, a specific US system, accountable care, integrated care, comes under many names, health maintenance organisations, that it turns out has been part of all the major policy changes and legislation from 1990 to date, including the legislation that passed this year. And we'd like to be talking about that and what it means, what it has meant, in fact, not as a future thing, but what it has meant for our access to healthcare and our healthcare in the UK. We don't have a video, do we? No, we don't. And so we have David Himmelstein from the US, who I hope will give us a perspective on accountable care and what this means in terms of the growth of corporate power in healthcare within the US, and Deborah Harrington, who writes about and researches the influence of that model on the UK, and Mary Whitby, who has been a campaigner very much aware of these issues and trying to bring these issues up in her campaigning, rather than just follow the sort of common demands for more resources, which fall short of addressing a much deeper problem, which is a change of direction for healthcare in our country. So at some point soon we'll hopefully have a little video intro that I made earlier, but we can start. I just wanted to ask you to begin with, because there isn't a widespread recognition, even among campaigners. There isn't a widespread awareness of US influence on British healthcare. I mean, even on the left of politics, you hear people like Richard Bergen. He talks now about Americanization of healthcare, but when you listen or read what he says, he's actually only talking about, he talks about underfunding. He's not actually talking about specific elements of US state-provided healthcare that's been copied in the UK. So we're really lacking sort of a widespread awareness on the left of what that influence has meant. And there's a very dangerous situation where the idea is spread, even among the left, that we still have the NHS as it was designed to be, but just lacking the means to do what it was supposed to be, whereas actually it is in process of closing down the services that provided the care that it was designed to provide on purpose, in order to restrict the role of the state and expand the role of private healthcare. And this works both in terms of creating work that's easy to do for companies paid for by the state, publicly funded, and also in terms of making you
turn on that light. I thought I had it on, but it's got turned off somehow.
Sorry. Pushing you to go private if you want anything more than the basics, which is increasingly what the direction we're going in. So from a perspective of a campaigner on the left, I'm going to ask Mary to talk about a bit more about campaigning in relation to Labour councillors in particular. Just give us a flavour of that, if you would. Just.
Okay. Well, I had a massive learning curve over the past 6 years because I knew that they were privatising the NHS. I didn't exactly understand how they were doing it, the structure of it. And then, through meeting people like you and Deborah, and other campaigners joining the Save Liverpool Women's Hospital campaign, and hearing Dr. Bob Gill speak as well. You hear different perspectives and you start to put all the jigsaw pieces together. And you know, we through the campaigns locally, we have a collective campaign with Save Liverpool Women's Hospital, with Defend Our NHS Wirral, with Keep Our NHS Public Merseyside. And we've worked together across the whole footprint of the integrated care system that affects this area of Cheshire and Merseyside. And we tried to raise awareness because, as you say, the messages are just not getting out. People didn't believe the NHS was really being privatised. They didn't believe any politician would really do that, because all the politicians tell them they support the NHS and the media doesn't tell you what's happening. So you've got to do some research yourself. So we decided we needed to get the message out, and we needed to try and build a mass movement to build a movement so big that politicians can't ignore you anymore. They have to respond to you. I mean, unfortunately, the Labour Party has gone back on all the policies, despite, you were involved in writing the Labour Party conference policies since 2017, and they've kind of reneged on those policies. So we thought we needed to talk to people on the ground. So we went out and we did stalls in the streets, but we also engaged with councillors across the board, and we've emailed, I think there's around 600 councillors in this footprint, and we've emailed them lots of times, and you could probably count on one hand the number who've actually responded and engaged with us, unfortunately. And I don't know whether a lot of them just didn't understand the process. They hadn't been properly briefed. We did offer briefings, we sent them information. Whether they read it, I don't know. It's been quite frustrating.
Yeah, I know a bit about that, and I sympathise with that. And yes, you mentioned the policy and the learning curve. I mean, a few of us in the campaigning have gone through that. And if I can talk, in my case, in relation to the Labour Party, a group of activists, we wanted, from 2011-12, we thought to lobby, through conference, pass motions to demand Labour really opposed the process that included the Health and Social Care Act of 2012, and what looked like reticence to go all the way, or to shyness about really defending the service, over time has turned out to be a commitment to policies that undermine the service. From picking up on research that's Mary's mentioned, Alison Pollock's work, stuff that is out there, but it's not really reflected in the way people talk about the health service in the mainstream, and not only through the Labour Party. And obviously the problem with the Labour Party talking about these things is that they're complicit institutionally, so you really had to have somebody like a maverick, let's say, if I can call him that, Jeremy Corbyn, but you also needed more than that. You needed to organise in such a way as to impose a left narrative. And that really briefly happened when Diane Abbott was the Shadow Health Secretary. We started to hear about how companies like General Electric, other GE Healthcare, other US companies were involved in redesigning services across different parts of the UK in what Mary's referred to as footprints. The country divided up into 44 of those, which became 42 over the last few years. And so yes, the Labour Party there's clear reasons why after Diane Abbott did this, it kind of disappeared from. We heard that essentially with the problem was funding, that with more funding, the implication is that with more funding, the hospital closures that were happening under the so-called sustainability and transformation plans would be fine because there would be more money there. And I'd like to appeal. This is kind of an appeal to people on the left to talk about how the service has been restructured, and some people say that's a terribly off-putting word, how the familiar things like local GP and the local district general hospital that actually has an A&E in it that you can get to when you need it are being closed down as policy, not because They'd really like to keep it open, but they can't. But because there is a political decision to close them across the country, it's presented. You'll have seen that. Other campaigners have seen that. I mean, I'm told campaigners in Grantham, they moved the staff from that hospital to another hospital that they were planning to keep. A few larger hospitals within A&E, the major trauma centres across England, between 70 and 40 from 144 of those that we had in 2014, and yet local campaigners come to protest against the closures, and they're told it's because of some local thing, it's because of not enough staff, enough money. But actually in this case they moved the staff away first and then said, sorry, there's not enough staff, and went ahead with it. But every effort is made not to show that this is a national policy.
Got the video for you now.
Yes, do you want to play it? A publicly paid, no role when the National Health Service brought to all our doorsteps everything from the general practice to the general hospital. It knowingly wiped out the healthcare business. Bevan celebrated the innumerable harpies that battened on the sick and are slowly being eliminated. This event is about having the tools to correctly read and address how business interests have methodically been undoing that National Health Service, which they've had to do simply to create opportunities for profit. Straight away, let's look at one example of how destroying our services can create profit. Here, it's our 70-year right to a local A&E we can actually access when we need it. At this point, the BBC reported England had 144 A&E hospitals. Here, the author of government policy announced they were being reduced.
We're working with commissioners and with hospitals across the country to designate 40 to 70 major emergency centres.
Label 70 to 100 smaller A&Es as emergency centres that deal with less serious conditions.
They say the changes are temporary, but for the people of Chorley, the closure of their accident and emergency unit at 8 o'clock this morning will mean a journey of at least 20 minutes. Minutes former patient Jessica Knight didn't have when she was rushed there with multiple stab wounds 8 years ago.
Charing Cross A&E will be replaced with an emergency centre run by GPs and nurses.
Both Hammersmith and Central Middlesex hospitals have GP-led urgent care centres on site.
Urgent care clinics have become a $14 billion business.
We'd always wanted to break into the urgent care market because we knew that that's a growing area of outsourcing for the NHS.
Note, these UTCs created by destroying our A&Es are publicly funded businesses. But also bear in mind that when we all had a proper A&E to go to, who would even think to pay privately to go to a minor injuries unit like that? So simply by removing that right, in this case to an A&E, privately paid businesses can also compete with the reduced publicly paid for ones. This necessary program of destroying our services to create business opportunities, which runs across all our healthcare, provides the necessary context to ask the question, will Labour ever defend our NHS again? I'll be very specific about these words because these meanings have been turned upside down a lot. Labour here means the institutional party's basic position on the subject. That only rarely changes just because there's a new figure in charge. That's because these positions reflect interests which are permanent. Which brings me to what the NHS means. Because the political position is, either you pursue that founding purpose to bring everyone all the care they need, as only the state can, or, and this leads us to what defending it means, which is defending it from the other position, which is ceasing to provide that all-embracing service in order to create space for profit, as we've seen. Once you're destroying the services that brought everyone the care they needed, once you've spent over 30 years copying how US governments reward and encourage shrinking state services. Here's that in half a minute.
The fund holding practice concept owes something to the HMO experience in the United States.
There is an NHS Kaiser Permanente partnership in 6 areas in the NHS which are adapting lessons from Kaiser's experience in the US to apply in this country.
Torbay was part of the sort of pilot sites that were set up in alliance with Kaiser Permanente, who came over in 2003.
Not having to go off to hospital, that's the sort of future that we want. The example that you had from Torbay, where the health and the social care services are coming together, that's the sort of future that we want.
A specific system that creates profit mainly by eliminating inpatient hospital services.
It was the very competitiveness of that market that caused Kaiser to offer patients more clinical integration in order to survive and flourish in the marketplace. And they did this integration, my lords, on the basis of reducing the use of inpatient hospital services.
Once that has become your priority, your goal is no longer to put people before profit. It is no longer to provide a national health service. And that, I suggest, is the real NHS crisis. Faced with this, I want you to gauge Labour's institutional position to that destructive programme.
Labour's been very supportive of the 5-year full review. You, in a sense, partly made your name, Heidi, by the campaign over Lewisham's A&E and plans to downgrade that and maternity services. Some of the transformation stuff will see services move, services close, services shift.
We can't preserve the NHS in aspic. We need to look at how we use NHS assets better. There's a whole list of land and buildings that is supposedly surplus to requirements. So let's use the estate, the NHS estate, differently, and let's craft a story and a narrative in which the public can believe and where we can bring them along with us.
Why does Labour's opposition health spokesperson, even under a pro-NHS leadership, see it as the party's position to spin for the government? What does she mean by we? And what story can you tell from a position of supposed opposition that steers public debate away from the basic fact you no longer intend to provide a complete national health service, but to destroy the services through which it was provided, just to create profit? An effective way of turning a blind eye to this radical change of goals is making the story about the means to achieve the current destructive goal, falsely implying that it's still the original goal of providing the full service.
The NHS in England will only survive if services are cut back and some hospitals are closed altogether. That's according to the think tank, the King's Fund.
The King's Fund saying the government really needs to back these plans with hard cash.
It also matters for the left to have some historical memory. All was not rosy in New Labour's NHS, despite some short-term stats. Because despite the spin about business creating capacity under PFI, the real story was the same closures and downgrades to create profit that continue today.
They appear to have decided that the most important hospitals are University College Hospital and the North Middlesex, and that they will therefore downgrade or reduce everything else in between. I find that repugnant and wrong.
And which arguably are the real NHS crisis, with more money and with pretend opposition.
Billions spent, and yet morale is so low. Some hospitals still threatened with closure, departments shutting down.
Labour's position today remains the establishment one. Sadly, 3 parties, 1 goal, as it was before Jeremy rightly tried to make healthcare renationalisation into the story.
The NHS will therefore take the first steps towards true population health commissioning, with care provided by accountable care organisations.
Accountable care organisations. They are policies developed by this side of the House.
And before Diane Abbott briefly and powerfully called out the real agenda of US corporate-led closures of our services for profit, that is the correct framework to read what Wes Streeting means by this. I do think the system needs real reform in terms of the model of care. We are spending far too much money too far down the patient journey. We're pouring loads of money into hospitals because we failed to grip conditions much earlier. This is about reducing the care we need on a financial, not a clinical basis, which creates opportunities to present outsourcing as a solution rather than part of the core problem. I'm glad we could play that because it framed the idea that I wanted us to be focused on. It's often be hard to, because we even heard this from essentially from right-wing Shadow Health Secretary, right-wing Shadow Health Secretary, even though under a left-wing leadership, that the problem was not enough resources, not enough money, not enough staff, and some bits that are outsourced. Whereas in fact, the wholesale restructuring, the wholesale ending of the local accessible comprehensive services that we've all become really familiar with and for profit was not counted as privatization anymore. It wasn't discussed. So if you have that in the back of your mind, you'll look at, oh, a contract's gone out to this person, a contract's gone out to that company, that's bad. And you have campaigns, sort of mainstream NGO campaigns that get their members to write letters to lobby these US entities that are rewarded to keep reducing what care is produced, not to have private companies on the boards, as if having only supposedly state bodies, they're all arm's length bodies, they're not the NHS. They were created as part of this 30-year process of privatisation and reduction and breakup, such as trusts. If they have the contract, like that's going to be fine. Like this, that in some way, as if they think that this is going to bring, and it's what they say, it's going to bring back a national health service, and just blanking out the fact these are not local representatives of the national health service. They are separate so-called health economies, and they are whipped and rewarded to, given carrot and stick to do what is also national policy, but they're whipped and rewarded to keep reducing the things that Wed Streeting implies need to be reduced, which are being reduced, such as access to hospital. We have huge waiting lists, and it can't be unrelated. I'd like to ask David Himmelstein and to give a proper presentation to you, but of you. You're one of the founders of Physicians. Can you? I do beg your pardon because I should know and be able. But can you just tell us about the organisation you founded to bring and your campaigning for Medicare for all, and your research on access and related areas? And also, I know you came over to the UK to talk about accountable care organisations, to warn us, basically, but I don't think it was given a wide hearing at the time. So, forgive me if you wouldn't mind introducing yourself proper better than I have. And my question is, what advice would you give to campaigns who think that you can lobby our accountable care organisations to not have people on their boards who are from the private sector, the out-and-out private sector, and in some way that means protecting or restoring the comprehensive care to all that we knew as our NHS?
Well, I'm not sure that I have fair advice for you in the UK, but I can tell you about our situation in the US.
Okay.
So first of all, I'm a primary care physician by trade, and planned for most of my career to take care of patients, and found that our healthcare system in the US wouldn't let me. So about 35 years ago now, I, with a few colleagues, started a group called Physicians for a National Health Program, which was really to say we can't defend the programs for the poor. Those are terrible programs. What we need is a complete, thoroughgoing reform of our healthcare system to adopt a unified system that's publicly funded and controlled and available on equal terms to everyone in the US. And at the time, actually, our media thought that was a crazy idea. One reporter said to me, Physicians for a National Health Program, is that a sister organization to Furriers for Animal Rights? But in fact, now polls show that about half of all doctors in the US do support national health insurance of the type we've advocated, and about 60% of the American people do so. But our politicians remain quite strongly against it in the majority, in some ways quite analogous to yours. Even our Democratic Party, which is to a large extent funded by the health industry, is quite in favor of corporatized medicine in our nation. So let me just skip back and say I'm mostly retired from clinical work now. I do health policy research. I'm now a professor at the City University of New York in New York City, and retain my connection at Harvard University as well, where I spent 30 years as a professor. And our situation is that the small practices and small units of delivery of healthcare have been very actively wiped out by large corporate takeovers, and our healthcare system is now run by giant enterprises whose sole goal is profit making. And whether they're labeled non-profit or for-profit, they have the same incentives and behave much the same way. And let me skip back to the ACO concept. It's really a renaming in many ways of something we've had for quite a while in this country, and they've had to rename it because of the bad name it got in earlier era. We used to call it HMO, or Health Maintenance Organization, and in the 1980s and 90s, Americans were revolted by the tales of what happened to patients because of the profit-driven abuses of those organizations, so that the policymakers then said, well, we need a new name, and we'll call that accountable care organizations, but really almost identical things. And it also goes by the name Medicare Advantage programs, which is a program within our public health insurance system for the elderly. All of those systems have in common that a corporate managerial firm receives a per patient payment to then pay for the care of the population who are enrolled with it. And the per patient payment is adjusted for how severely ill the patients who that particular organization has promised to cover are. And then the organization, that managerial middleman, is responsible for paying the bills to doctors and hospitals and nurses and the other organizations that actually deliver the care. And what we found is that they have very quickly realized the incentive that they receive that capitation payment, and whatever money they don't pay out, they get to keep. And in the for-profit sector, that goes off to the shareholders. In the nonprofit sector, it goes to pay extraordinary incomes to the managers who are running it, and to build new palaces according to what they think will be most profitable for them in the future. So those organizations, some are run by our giant insurance companies, United Healthcare being the largest, and I think they have some entry in the UK as well. United Healthcare not only is an insurance company, they directly employ 60,000 doctors to deliver care. They run HMOs and ACOs and Medicare Advantage plans. In fact, now the largest employer of doctors in the US. Their CEO made, I think it was $351 million over the 10-year period between 2011 and 2021, and that's not including the $250 million severance package he received at retirement. And they make enormous profits off the care that they don't deliver. What we've seen is that the way to profit for those plans, and your artist Banksy, one of my favorites, actually summarized it. The best way to win is to cheat, and they cheat in several ways. One is avoiding unprofitably ill patients. So within a particular group of patients, let's say patients with heart failure diagnosis, some are very cheap and some are very expensive for a plan. And if you can get rid of the expensive ones, you get the same capitation payment because the diagnosis may be the same for the cheap and the expensive patients. But if you avoid the expensive ones, you can profit enormously. And there's extraordinary evidence of the kinds of efforts they've taken to avoid or eject unprofitable patients. The second thing you can do is to mislabel patients with diagnoses, and that tremendously increases how much you get paid by either the private sector or government for the coverage of those patients. So within our Medicare program, for instance, they now contract out the coverage for about half of all seniors to these private organizations. And the organizations can increase the payment from roughly $5,000 or $6,000 per patient to $20,000 or $30,000 per patient by attaching additional diagnoses. One of the ways they do that is to prod doctors to attach unimportant diagnoses that raise the patient's calculated risk score but have no clinical meaning for that particular patient. And what's been found is that they often actually fraudulently add diagnoses. Our Medicare monitoring organization estimates that $9 billion in excess payments were made last year because of completely fraudulent diagnoses that were attached by these organizations. A third thing you can do is to suppress the care of people whom you enroll once you can't get them to leave. And there are a variety of ways of doing that. I actually had a contract with one such organization as a physician, which paid me bonuses for denying referral care to my patients. I was the primary care physician in that plan. And if I made bonuses by saying, no, you shouldn't pay for the referral to the cardiologist or the accident and emergency department or a laboratory test, I got additional money as the primary care physician. And in fact, I could boost my income by about $150,000 each year if I made all of the bonuses and I had all of my patients in that plan. I wrote about that in the New England Journal of Medicine, and it turned out that that was offensive to the plan, and I got a letter from them informing me that I would no longer be a physician recognized to be paid by that plan. But I wasn't the only such physician who they ejected. There was a primary care doctor in Texas, Gordon Sack, who was voted primary care family physician of the month in July and was ejected in September because sick patients think that a fine physician is someone they should seek out, and you want to get rid of those sick patients. So that's the second strategy. Avoid, upcode, or increase the apparent illness as the second, and suppress as the third. And the fourth is that generally there are bonuses offered for meeting quality standards, and there's ample research that these plans fake their reporting of these quality standards in order to get these multi-million, $100 million and more dollar bonuses for meeting these quality standards. You know, one of my heroes, Julian Tudor Hart of Your Nation, wrote in 1992 that audit of practice has now become a practical possibility. But when you audit competing entrepreneurs and pay them based on the data they themselves provide, that data has the accuracy of a tax return. And that's what we've got now in our nation's healthcare.
Have we lost?
I think you lost my video for a moment, but I hope I'm back. Hello?
Yep. Hello, David? Can you hear me?
Can you hear me now?
Yes, we can hear you and see you.
Okay, sorry. I'm afraid I'm on a somewhat unreliable internet connection.
It happens. Fine. Thank you again for that. And I soon want to hear from Deborah, who's written about, perhaps you can find some points of comparison between things you've talked about. But a few occur to me, and one of them is the way you talked about the so-called non-profits and the way they work along the same incentives as the out-and-out for-profit organizations under the same system. And I remember seeing Linda Pino, who was famously in the Michael Moore's film Csergo, talking about health maintenance organizations, how she was promoted and had a much higher salary on the basis of refusing care. And she made the point that it's the same, whether if it's non-profit, then it's called savings, and if it's for-profit, it's called profit, but it's the same thing. And that that means it's the system itself and the incentives themselves which are the problem, which I think there's been a concerted effort to falsely reassure campaigners and others and people who might otherwise have been a problem that that the system itself that we've inherited from you, not you personally, is fine. As long as, for example, it's not a private company and or certain conditions are met, or there's sufficient funding and so on. But we're seeing the same structural idea of profit incentivizing denial of care. We're seeing it here. You mentioned the bonus you were offered, and in 2015 the BBC reported here on GPs receiving those incentives to not refer patients to hospital. And so these things pop up. And this is something Deborah has talked about. They pop up in the news. And another thing was in the Daily Mirror centre-leftish paper here a few years ago reported that Optum, that's part of United Healthcare, had been given a big contract to rank patients in the UK according to how much they cost, which is what you've been talking about. You're talking about you can't really exclude, I suppose, the expensive, unprofitable patients unless you know who they are. And there's also been a lot of campaigning here around the use of data, but this has been absent as well. Why is the data being collected? And my understanding is this is one of the reasons, so that you know who to exclude, who to keep out of hospital, who to keep at home, as much out of the way as possible, as cheap as possible, from the shiny care, which is no longer considered a right for everyone equally. And those are two things that occurred to me, and I'm sure there are more. Perhaps Deborah can speak to.
Can I just interject two
yes,
brief
please
things?
do. Yeah.
Well, one is, it's really unfathomable why it is that anyone in Britain would think that the US is some example of the healthcare that you might import. We spend twice what you do on healthcare per person, and our outcomes are incredibly much worse than yours. We live 4 years shorter on average. But the second point is there's an impression that the US healthcare system is largely private. In fact, 2/3 of our health spending comes from government at this point. Our government spends more on healthcare by far than yours does. So public funding and private control is the description of our healthcare system. And in fact, 60% of the total revenues of our private insurance firms now come from government.
Thank you for those points, and I think people often talk when they compare the US and Britain. What people mostly look at is a bill from an insurer or problems with an insurer, and the context of it, and the fact that we've been copying what the US state does in its programs like Medicare and Medicaid doesn't really come up, but it's without the state reducing and keeping to a minimum what it provides, people wouldn't be forced into the arms of those, I understand as well. And then there's what you've said about that the huge proportion of the funding comes of the profit comes through that. So people underestimate. I think I've seen some counsellors who went on a visit to the US try to reassure journalists or local people that it's okay. We were just looking at Medicare. We weren't looking at it wasn't a private endeavour that we were learning from. Like that was fine. Yes. So yes, I think that's a huge point. Thanks for making it better than I did. And perhaps Deborah can talk, and we can come back hopefully and further on ahead as well. Hey, Deborah.
Well, thank you for inviting me, Nicholas, to be on the panel. And it's, yes, I mean, I have my notes here, what I was going to talk about, and I've been sort of amending it as you've been going along because there's been so much raised. And certainly on that last point, I mean, we, Public Matters did a briefing for MPs and peers before the legislation that was passed this year, the legislation that brought the integrated care systems and care boards into being. And in fact, we did, David, raise particularly that point, and actually what you just said as well, Nicholas, that there's a false impression often given by campaigners, I think, that when we're talking about America, we're talking about privatising the NHS and bringing in insurance for everybody. And in fact, yes, of course, the insurance in the States, as you've just said, is to a large extent provided by the US government. That's who's funding it for a lot of people, for the Medicare and Medicaid and the Veterans Association programs. I don't think that, well, the figures we had at the time, I don't think that your government spends an awful lot more on the public programs than we do in total. The difference, of course, is that our program was designed to, and did until fairly recently, cover absolutely everybody in the whole country for everything from cradle to grave, no exceptions. It was, that was the system, whereas your equivalent or slightly larger amount of money from the state pays for a reduced amount of care with quite severe limitations in some cases. Say the same amount of money, slightly more, but for a lot fewer people, a smaller percentage of the population. I mean, I think that's if you were to multiply it up, your government would really be paying a huge amount. I mean, even it would even surpass the total that you're paying now, which I think is around about 18-90% of GDP on healthcare if you take both the public and private together. Yes,
but actually, Deborah, if I could just interject, the figures you cite exclude the huge tax subsidies for private insurance, which cost about $250 billion each year, and our budget lists as a tax expenditure in the
I stand corrected, David. Thank you.
and 25% of the employer-paid private insurance market is public employees. So, in fact, our government spends 60% more than yours in total per person.
Okay. Right, so I mean, I am wholly in agreement with Nicholas that we talk about the wrong things quite often. It's I think there's a kind of conjurer's trick that goes on to make us look the other way. It's very clever. It's sort of like while you're looking up here, something's happening across here. So I think that I'm sort of going to talk about why we think what we think and why it's changed so radically since the creation of the NHS, that are about political and social culture. Just as an example, this might seem slightly off, sort of a bit left field, but we've just been through the spectacle of the media in overdrive over the monarchy following the Queen's death. And my friend and ex-colleague, Dr. Helen Salisbury, tweeted to say she'd been asked if she'd be on the radio where they wanted her opinion about what had been the secret of the Queen's longevity. And statistically, said Helen, her wealth would have been the single largest contributor. And the programme decided they didn't want her on after all. And what Helen said had jarred with them. It wasn't untrue, it just wasn't welcome. And I do actually think that the problem for us, in a sense, is that proposals for the restoration of a public service NHS fall on deaf ears because it isn't welcome. It doesn't fit with the current narrative, doesn't fit with the story that we're being told. Many of those who actually support the NHS, who would consider themselves to be firm and committed believers in the NHS, and by the way, I have kind of issues with that myself because I don't think that a system is something you believe in. It's an actual organisation that has functions, it has a public reason, it has put politics behind it. It's not actually a faith, despite the kind of often quoted thing that the NHS is the nearest thing we've got in the UK to a proper religion. It isn't. It's an organisation and needs to be looked at and studied and scrutinised as such, and to see whether it's producing the outcomes that that system ought to be providing. And if it's not doing it, then questions have to be raised. The questions that aren't raised is the extent to which the modifications that Nicholas has been talking about, the gradual changes, how much that has affected our outcomes, which, David, are heading south to join yours. We had much, much better outcomes than we're thinking. Many of those who support the NHS say they don't believe it's changed in essence anyway. They just think it's a lack of money. And they characterise the problem always as bad Tories underfunding and outsourcing, sometimes with addition to their mates. And many at conference, I'm sure, will have a solid belief that the NHS belongs to the Labour Party because they created it in the first place and only they can rescue it. And on the other hand, and the far more powerful group, there are policy groups, think tanks, lobbyists and politicians who have changed the climate of opinion away from public service, characterising it as centrist, monolithic, bureaucratic, slow to change. At best, it's personified as a romantic but completely unrealistic and unaffordable dream, and at worst, it's a Stalinist monster. I think that's quite something, David, you hear quite often in the States when people talk about the NHS. Socialised medicine, it's awful. You have to wait 1,000 years to be seen, and so on and so forth. There are all these kind of myths that are propagated about it. These people insist that the problem with the NHS is, although it's a good idea in principle, they always say it's a good idea in principle, they might even say that they love it, that it needs reform to make it work. We hear that word all the time. Now, Nicholas has spelled out just how many changes have actually taken place that take our attention away from the actual principles, the things that they say is so good about the NHS. Its principles, actually, everything that's happening is taking us away from those principles. And where the thinking has come from, as he says, very much from the US influence to drive those changes, and how our once national, comprehensive, accessible and universal service has been dismantled. And it's interesting to contrast the way our politicians use the word reform with David's use of the reform, which he said, in which he literally means making US healthcare better for everyone. In our case, Universal went with the immigration bill when we started charging people from other countries. Comprehensive went with the 2012 Act and the subsequent 5-year forward view and the removal of certain treatments from the NHS offer. Accessible has slowly disappeared over the years as community and district general hospitals, psychiatric and maternity hospitals are being closed or downgraded. And National, the big one, that just got chucked up into 42 accountable integrated care systems in the last Act. And if you've been listening, still every single Prime Minister and Secretary of State for Health, sometimes with a Treasury or business spokesperson thrown into good measure, calls for reform. And statements have been made from various cabinet positions that public service employment should be denationalised too, with local pay agreements in their place. Anyone giving that 2 seconds thought will realise that that is going to increase inequality in health provision massively, as just by the way things run, the poorer areas will be offering lower pay because they won't be able to afford to pay higher pay. And that's the government's intention. If you live in an area where housing is cheap, well, they don't think you need to be paid as much. And all of this is in the service of public-private partnerships and personal choice, sometimes with the addition of personal responsibility thrown in. And it's been the dominant political mode since 1976, not since Thatcher, but since the 1976 IMF loan. Economy is tanking. Oh, the economy is tanking. Check the papers today, it's all over the place. And underneath all the other reasons, it will tell you that it's excessive government fiscal spending that's the root of the problem. It's when governments spend money, everything goes wrong. So of course the NHS is a problem because it spends a lot of money. It wasn't easy to dismantle the public love and support or it hasn't been easy to dismantle public love and support for the NHS. And that's why politicians still say that they love it too, even though they're doing all the work on it. When they created the NHS, Victorian poverty, 2 world wars, a flu pandemic and the Depression, well, that all gave a very strong argument after the Second World War for government intervention, and full employment, social security, rising literacy and numeracy, better housing and health also led to rising wages. So there was a good reason for people to believe that this was a really brilliant thing to do. But Julian Tudor-Hart, who David's already referred to, Welsh GP, founder of many important healthcare and prevention initiatives, a powerful author and the life president of the Socialist Health Association, wrote, since the 17th century, objective analysis of social health and care has endured repeated cycles of birth decline and rediscovery, always related to contemporary political and economic climates of democratic advance and oligarchic retreat. The post-war period can be seen as democratic advance and a pushback, as Nicholas quoted from Bevan very specifically, pushing the private sector out of the public realm. And so a pushback on the influence of business on political process. And what we are seeing happening in the NHS and the wider political sphere has to be seen in the context of a 40-year period of democratic retreat and oligarchic advance. When Bevan, the creator of the NHS, resigned in 1951 over the funding of the war machine instead of public services, he said that in respect of the NHS, he objected to the artificial ceiling on its budget, saying it would not allow for rising prices and therefore would involve making cuts. This is the beginning of the end, he said. Once you start this, there is no logical stopping point. Well, when you think of that all those years ago, and you look now, and if you think, well, it might be failing, but we've still got an NHS, it might sound ridiculous. But he was right. He knew the enemy was at the gate right from the off. And although I think he'd have been surprised at how hard they would have to work to destroy it, he would still have expected it to happen. And it's been done by this process of culture change, instilling into people the idea that there's this thing called the economy, which is somehow separate from what happens in our everyday lives, and in which the public sector is like a huge anchor weighing it down. This burden can only be lifted if the private sector is strong enough to do it. And we, the people, don't take enough care of ourselves. We're too old, we're too fat, we're too demanding, we're soft and we're lazy, and we've got so used to state coddling us that we can't stand on our own 2 feet. All of this matters in the dismantling of the NHS. It makes it possible. You have to build a culture, you have to create a different kind of set of principles behind it. And it's doubled down on with public praise from Jacob Rees-Mogg for the philanthropy of food banks, for the calling of people to step forward to offer their homes to Ukrainians, for the introduction of volunteers into our emergency services, including the NHS, to help relieve the terrible financial burden. Well, Nicholas has focused mostly on integrated care and the simultaneous reduction in the public capacity to provide healthcare and the expansion of private, the very deliberate process that's done that. He described the influence of the US health insurance industry in the redesign of our public service to serve corporate interests. But in the video that he showed, Heidi Alexander refers to property and land. And there's a whole lot of profit to be made from each aspect of public provision, not just clinical services. And if you sell the land, usually on the cheap, to private sector developers, there's an awful lot of money to be made. We've also seen some hospitals greatly increasing their private patients, not the private sectors, but NHS private, but only in areas where there's profit to be made. And some others have formed joint companies with US hospitals, like HCA, to provide private healthcare. My local hospital is Guy's, and they built a brand new cancer centre, and 4 floors of the cancer centre are the private sector, HCA. In the same building with Guy's NHS Cancer Centre provision. The newest of all of these is the US Mayo Clinic's first clinic in the UK, which is a really, really prestigious building, which is being built in partnership with Oxford University Clinic, building it right in the centre of London, a partnership itself between Oxford University and Oxford University Hospitals NHS Foundation Trust. Many of the hospitals, clinics and GP surgeries, which used to be publicly owned or owned by the GP partners, have been sold or taken into ownership of NHS property services, and they've had to move either into PFI buildings or otherwise rent in purpose-built accommodation owned and provided by the private sector. Again, property is an incredibly profitable business. And offshore funds have brought up about half of the equity in PFI and PF2 projects. So the project's owners are increasingly remote from the public service that's even being delivered. In fact, they have no connection with it. And in addition, of course, the offshore owners of these projects pay very little tax. We've got lots of other things: maintenance, cleaning, hospitality, portering services, ambulance patient transport. These have all been moving over slowly to the private sector over decades. And even the NHS trusts themselves are forming their own private companies called subsidiary companies in order to provide them. And they're competing for business with the private sector to try and get other hospitals' business so they can do it too. David talked about the move from small hospitals and GP services to corporate ones. This is all part and parcel of Nicholas's overriding description, the kind of envelope he's put this in of accountable and integrated care. But the move from small hospitals and GP services to corporate ones. And we see the beginning of this here. Well, in fact, it's already quite well established, really. We've got Centene, a major US insurance company, which owns the practice, the largest GP group in the country, which spreads from Birmingham up to the northeast and down to London. There was quite a noise made by campaigners when it acquired 49 more practices earlier this year. spread across London from 18 medics. It now has 500,000 registered patients. That's a number which is inconceivable for a normal GP partnership, the traditional NHS model. Optum, the UK's subsidiary of US giant United Health, provides services to the second largest GP group modality, and I believe, I haven't reconfirmed this, it was proposed to be the fund hold of the new GP primary care networks. Samantha Jones worked for NHS England in developing integrated care, moved from there to Centene UK as its CEO, and then to Downing Street as a senior civil servant advising on the NHS. Now, there's an awful lot of people, including politicians, who have been through the revolving door from the private sector back into public realm, back again, always building and strengthening those connections between the public and private sector. Of course, an awful lot of NHS managers were sent abroad to the US, to Kaiser Permanente in particular, to be taught by Kaisers. Kaiser have a global training program for how to teach people how to run Medicare. So we've had a lot of people who've been to do that. But also, as an example of the way that the media moderates the message and only puts forward bits that it wants to, the Nursing Times headline, when she moved, said, ex-NHS nurse gains place at in number 10 Downing Street, rather than ex-CEO of Centene UK. David also talked about referrals, and I think that's a really key thing. Optum also runs referrals checking services, as Nicholas was saying, talking about stratifying patients into how expensive they were. And we now have referral checking services where your GP used to make a referral for you to go to a hospital or some other service, whatever it might happen to be, because they thought it was clinically necessary. It now has to go through a budget check to find out whether or not it's viable for you to have that service, whether is your life going to be long enough for you to be worth having a hip replacement or whatever it might be. So yes, GPs are losing NHS business. Even the idea, the concept that we have, that people can talk about losing NHS business is extraordinary. And as are community pharmacies in rural areas, to large pharmacy chains like the US-owned Boots and supermarkets, although through competition for profitable work, such as giving flu jabs, or through the withdrawal of essential funding. With the increased complexity of operating all the billing systems, I'm sure David knows all about the complexity of billing systems and legal arrangements that happen within ACOs and integrated care, and not to mention the backroom services such as developing and running IT systems and patient-facing IT, the GP at Hand app. There's a lot of lucrative work for major accountancy, legal and management consultancy companies to be had too. Can't even begin to start talking about the data. I mean, just briefly, the NHS data set, with its over the period of time it's being collected and the number of people it covers, has got to be one of the richest data sets in the world, health data sets in the whole world. And that means big money for a whole number of different companies, whether it's selling you services, including insurance, or actually, when it comes to integrated care systems, looking at whether people are profitable or not, who are they, who are going to be the expensive clients in the future. And with all the emphasis on business, we are also chipping away, breaking up the basic principles inside the NHS itself. People clapped during the pandemic. We all said they were heroes. Actually, it's changing, I think. I think that inside, and this is almost like anathema to say this, doctors and nurses, other clinical staff, and NHS management being encouraged to come up themselves with bright ideas for how to make money. And there's a whole thing called Doctorpreneurs. It's a global business in which you take bright health people and you to develop, you give them the funding and the backing and the pushing and the marketing to create ways of making money out of the NHS. So what we don't have anymore is the NHS as a unified provider of universal and comprehensive services. Funding the NHS to provide what's needed where it's needed is no longer the prime objective. We're halfway to Medicare with all the right business processes, billing systems in place. Medicare for all, David, might be a huge step up for America. I'm really sad to say it's a very big step down for the NHS in England. I hope I haven't gone over too long, Nicholas.
Thank you, Deborah, for that. I'll pick up on one or two things. You mentioned Heidi Alexander, representing Jeremy's Labour, supposedly, but she was waving this stuff through and saying all the stuff you said about sales of property and so on, and all the money that's to be made in that, which comes from closing services, and saying, well, this is surplus now because we've closed the service. There's not enough staff because we sent the staff somewhere else, so sorry. She was waving that through and talking about giving us a nice story to make it sound fine. And what I would like to appeal to is that we're kind of rudderless in terms of, when Jeremy was elected leader, we needed somebody who had, as we saw in a small clip, stood up against. A lot of people thought that the closures under Tony Blair, it was a popular, there was a lot of popular anger raised, and the BBC said it looked like it might raise as much as the poll tax, protests had. It might reach a point where it was like that at some point. It was significant, and we saw a bit of David Cameron taking advantage of that, and there's amazing speeches where he sounds like he's defending the NHS. The one thing they didn't say, and while calling out the fact that we were losing our services, is that it was done for profit. He was called out by a Labour rebel, saying your motion is worthless because you're not calling that out. And we've been governed by a series of parties that are all committed to this. And you speak to the union, you speak to somebody representing the TUC, public services, they don't want to campaign against this. They are in favour of, they don't want to campaign against privatisation. And the health unions have been roped into a government body, remember the name of it? But they've been roped in at the top for integrated care. So Transition Partnership Group was part of the name, yes. So this is something Patricia Hewitt, somebody, an activist researcher, wrote about. New Labour minister created this because the unions were getting in the way of what they were doing to the service, and it's still there, and it comes from Labour. And so when Jeremy came up as a leader, that we needed that. It wasn't a luxury. It wasn't an extra. The question really at the election was, would we have an NHS or not? He was the only leader who potentially would be offering one, but he wasn't enough because the rest of the party had to go along with it. And essentially, although we heard about the destruction for profit for a bit, we heard opposition to that when we had a left shadow health secretary, essentially. That disappeared. We're not hearing about a lot of this stuff, and I don't mean going into a lot of detail, but I mean just the example of population health management, that it's classifying people according to cost. Is there any opposition to it? Who is opposing it? It's one thing to say, yeah, we want that surgery to stay in public hands, and there to be more funding. But what about something that's completely upending the whole point of the service? Where's the opposition to that? And there used to be that in Labour. You watch Labour's opposition to the internal market legislation in 1990, and Jeremy Corbyn and Tony Benn are in line, or vice versa, with Robin Cook, the Shadow Health Secretary. They're all kind of on the same page. And they're talking about the things we're talking about now. Corbyn and Ben talked about, a doctor having to check their calculator before they check the stethoscope, which is what you've been mentioning. But that went. We had that party, we had unions, we had something, and all those institutions have kind of crumbled away in terms of supporting what they used to support. So I'd just like to appeal to whoever's listening on the wider left to please look beyond just the things that you get from the NGO-y campaigns, the ones that want your signatures, the ones that need more followers, the ones that get funded, the ones that get apparently advice from really rubbish advice from people who've told them that, ICSs were really bad before they became law, but now that they're law, they're just part of the NHS. And that's it. And there's nothing to see here. And people are still talking about the 2012 Health and Social Care Act because that was so bad. But what's happened since has been a kind of silence. And that says something about the deeper corruption in our society than just the Tories. It's not just the Tories. It's very widespread. And it happens when a doctor is offered a bonus, as David was, and as British doctors are, and they don't all refuse it. To go along with that, as David described, and if we do care about this, please campaign for healthcare renationalisation. Make that the demand. It's not a bit more funding and then one day maybe, we can't talk about. No. Now is the time to talk about restoring the health service as it was created. Now is the time, before you ask for energy renationalisation, before you ask for gas renationalisation. Healthcare, remember it. That's my little appeal. And I know you're taking lots of notes, and I'd like to shut up and hear you.
Won't be able to follow them.
No.
But yeah, I think it's the weasel words that are used, isn't it? And it's the misleading words that the media use and the propaganda. And it's still free at the point of use. But if it's been shrunken to such an extent that it can't cope anymore, that we've got over 6 million people on waiting lists, it doesn't matter if it's free if you can't get into it. I think of it like a pint of lager. If you've got a pint of lager, and people say all these excuses as to why you can't get treated, but if you try to pour a pint of water or a lager into a half-pint glass, it's not going to fit. It's going to overflow, and you're going to have, pouring everywhere. Just like we've got people on trolleys in ambulances and in corridors, not able to get the care they need. It's not. It's at the front end, isn't it? They're causing the problems by shrinking the NHS and denying us care in that way. And this has been going on for years, because here in this area we had a campaign in 2019 against Warrington Hospital, which had a private price list for treatments that they said were of low clinical benefit, and they said they were using spare capacity while we had big waiting lists. And we said, well, how can you have spare capacity if you've got people sitting on an NHS waiting list? You haven't got doctors and theatres sitting, twiddling their thumbs with nothing to do. And they said, they were procedures of low clinical benefit. But then again, why would any doctor do a procedure on you that wasn't beneficial and you didn't need it? But as long as you paid, you could have it. So after 2 weeks of action outside the hospital and delivering 5,000 leaflets, and we got it into the newspaper, into the Daily Mirror, and it was talked about in a parliamentary committee, they had to pause it. And the chair of the hospital left, and she was also the chair of the integrated care system. But had she pushed that through, it would have been spread across the whole integrated care system. And these are, we've got a cost of living crisis at the moment. We've got energy hikes. We've got people unable to feed their children and heat their homes. We've got a local consultant paediatrician, Ian Sinha, and he talks about babies born into a cold home will spend their first months trying to fight off hypoglycemia and hypothermia, whereas a baby born into a warm home spends its first months building muscle tissue, building brain tissue, liver tissue, and those children are the children in the cold home are at a disadvantage immediately. And then if we haven't got a national health service on top, how are they ever going to become well enough to fulfill their lives, live a full life, and to grow up, to get a decent job, and care for their own families? So, but at the same time, we're told, well, we can't afford it in the 5th or 6th richest economy in the world. But we're never asked, can we afford wars, or can we afford the latest motorway, or can we afford a royal wedding? Or can we afford to excuse the royals of 400 billion pounds of inheritance tax? So, this is, in the real world, people are suffering. There is unnecessary pain and suffering and unnecessary avoidable deaths that people are suffering because they cannot get the care and the referrals they need. And I just think we need everyone to start demanding the return of our NHS, the way it worked, the way it was meant to work, to cover all our needs when we needed it. And unless we all get out there, the politicians are just not listening to us, and the media's not listening.
Thanks. Yeah, what came up a few things you're saying. You're talking about the media and the narrative from there, and this is the problem, that if it was only the media, if it was only the Tories, but the narrative that it's not that invisibilizes all the closures and the reduction in the service and the policies to do that. We saw, the author of the body of these policies over 8 years, Simon Stevens, Tony Blair's advisor, who went to United Healthcare and then came back to the UK, having learnt over there to apply what he'd learnt. We're not hearing a different voice. Is what I'm saying. It's practically hegemonic. That the discourse that it's not that they're cutting services, it's not that they're closing them, it's not that they're paying doctors bonuses to not refer you. It's just there's too many of you. There's too many people, too many old. Depends. You can blame people for being old, for being foreign. Basically, too many, and rather than the state's role to provide for everyone, whoever they are. And it's the absence of a response to that, even from the wider left, saying they are cutting services, there aren't too many people, because it sounds bureaucratic, it sounds technocratic. MPs, we were told by a left MP, they get their briefings from the King's Fund, which is the one that was saying that hospital closures need more money, the closures need more money, and the Nuffield Trust. The Nuffield Trust worked with the Commonwealth Fund, which is the one that's always quoted for saying that, their healthcare was so great in 2010. They worked to get the US and the UK to sign a bilateral agreement on healthcare in 2001. We were talking about a Trump deal. Well, we'd learn a lot more from what's already happened and to be able to deal with what we have now, then keep saying it's one future thing, putting it off renationalisation, putting off corporate influence as a future thing. It's not, it's now. And there aren't sufficient voices with a narrative saying, you are closing the services and telling us that there's too many people. We're not going to accept this. Bring back the services. The newspaper said, the Telegraph said they were closing the A&Es, and then they act like it's not happening. The same media, I use clips from Channel 5, sometimes the Mail, sometimes Channel 5 has the odd bit of what's really happening. And then it's just like it never happened. It just disappears because there isn't a body, there isn't an organisation, there isn't one. There really isn't one that is, a popular one with members and so on, where you mobilise people to oppose the core destruction of what the health service is. So I'm appealing to people to take it more seriously than anything you hear, because it is more serious than that, and we've heard glimpses of it. It's the common narratives that we have are not enough. It's a radical loss of the service. Okay, and I've made a long speech.
But as you say, there is no one coming over the hill to save us. There is no knight in shining armour. It takes each and every one of us to get out on the streets, to join a campaign. There are campaigns around, certainly in this region, and or join a union. Build that mass pressure. That means that our political leaders and our union leaders have to listen to us, that we set the agenda. We say, rather than the corporate lobbyists who are in those organisations telling them this is how things have to be, we need to say, well, no, we've had enough is enough.
Join an organisation, join a union, and then question what those organisations are doing if it's not enough, if it doesn't meet the reality of what if you're looking into what's being done to the service. What we needed to do in Labour, democratise and bring our support for public services, all of which are being taken away for profit, and bring that into political expression through organisation. And that was crushed for that reason by politicians who believe in the opposite of what we believe in. I just can't overemphasise the need to find out personally, read from Public Matters, read about what the corporate influence and the US influence is on our healthcare, and do what everybody can do what they can to try and push for there to be resistance where there isn't any. That would be a start of something. The problem is the lack of resistance more than the narratives that we don't have on our side.
So some of the things that we did was we went out to constituencies last year when the bill was going through. We particularly targeted Tory MPs at that time because they have the majority, and we set up stalls outside their offices. And one of our best successes was when the Tory MP, Sarah Brickcliffe, accused us of intimidating her staff with an embroidered handkerchief. And her dad, who was a veteran councillor, he had to then say later, I wasn't intimidated by a handkerchief. But it got us publicity. And half of the MPs we targeted with those stalls across Lancashire and Greater Manchester abstained on the bill at the next reading. And what we also did was we built a network of people across the whole region, across Cheshire, Merseyside and Lancashire, where we've now got people who will set up stalls in those areas and talk to the local people and give out leaflets and try to raise awareness. And that was really helpful and useful. And we also went to, the fan supporting food banks, their food pantries that they held every day throughout last summer. We were there every day with them, setting up our stalls, and we also joined the Bakers Union on their stalls in Wigan. And so we're building that network, trying to build a mass movement to raise awareness and to get people more active. And I think that the more people that can do that, the better. The more people doing what you're doing with change. If you've been able to change something like you did locally, imagine that on a wider scale. David and Deborah, David in particular, Deborah has spoken recently. If you've got anything to say to add to us, we're going to be closing soon. It doesn't have to be a word of advice, but something you've learned perhaps that might help us here down the road, or might not. Try us.
Can I say?
Yes.
I don't think you hear me. Yeah.
Yes.
I think one of the things that we've talked about media. We talked about. David talked about the money, the amounts of money that have been, in America. The same happens here. Vast amounts of money are poured into making sure that these changes happen, and we don't have vast amounts of money on our side to combat that. But what I think what we can do potentially, or if people put their minds to it seriously, is change perceptions by. As I said, I was talking about the kind of framing behind the idea of the NHS, the idea that the public service itself gets characterised as centrist, monolithic, bureaucratic, etc., and slow to change. And there's the affordability issue. Now, the left tends to respond when asked how are we going to pay for the NHS to say tax the rich, tax the corporates, get the money from there, rather than actually making a strong argument about the fact that it is always affordable. You don't. If you do that, you're playing on their turf. You don't play on their turf. You construct your own way of talking about things. Similarly, people. I've noticed certainly from younger activists that when they're confronted with this idea of the 1970s, it was really awful. We had this bureaucratic NHS, and it didn't work properly, and it was really terrible. They say, but we need a public service for the future. And while it's true that we need a public service for the future, we always need a public service for the now, not for some time in the past. It's still the idea that you respond and react reflexively to this accusation that it's a terrible bureaucratic monolithic thing, rather than actually focusing and concentrating on its strengths and its magnificence and its utter beauty as a concept of reporting the population and the people who need it.
Thanks. In a nutshell, I'd say.
Quick observation.
Please.
From an outsider, the changes in the NHS have brought enormous increases in the administrative overhead and the waste of resources in Britain, as they have in the US. And actually, one of the things in the US that we found a powerful argument is that the incredible inefficiency of market-based policies in healthcare. I mean, we employ 1 million unnecessary people in our healthcare system in the US whose sole responsibility is enforcing inequality and collecting profits. And if we had the efficiency of the old NHS, we would save $600 billion each year in the US. And in the UK as well, your system is increasingly inefficient as it becomes increasingly market-oriented.
Thank you. And we're sold the ICS concept as efficiency, aren't we? Both in the US and here as a way of making savings, and that's what the ICB board people are saying that they're concerned with, because they are rewarded for spending less on healthcare from the budget, which doesn't mean the same thing at all. I think fundamental is to remember that what benefits us as a society is a problem. In this case, we're talking about it's the problem that corporations had, and they've had to get rid of the thing that worked for us, and that there is a class struggle there. There's a direct contradiction in interest between the two, and that's the basis for understanding when they take a service away, somebody's benefiting from it. That's why they're taking it away. And the people who are doing the work of taking it away are also being rewarded for it under the ACO system.